Well, I'm back, and we're talking about communities leading the way. In light of some of our previous conversations and other panels before, I wanted to talk about how we can get these conversations at the community level that are developing and groups of people that are maybe at the cutting edge. How do we get capital P policymakers involved in that? Erika, I wanted to ask you first, in your capacity and career in community engagement and also in advising elected officials, how do we do that?
Thank you for the opportunity to be here today. So in Columbus, Ohio, I lead CelebrateOne. We have a team of 72 community health workers. They are from 8 of our most disenfranchised neighborhoods around our county. And we utilize them not only to help moms and walk alongside moms and provide education and guidance over barriers related to social determinants, but then those health workers come back in and they download with us and with our policy committees and with our teams. CelebrateOne is situated in Mayor Ginther's cabinet, and so what we learn, we share across the cabinet. So if we have neighborhood safety concerns or perception of safety, the director of safety is there, and there's some insights we can share. If there are housing concerns, which we have many, I think everybody does, affordable housing, housing for homeless pregnant women, all of those situations, we can bring that to a cabinet level. We then, quite frankly, leverage the mayor's interests to bring other partners to the table, county partners, our state representatives as well, to come up with a comprehensive solution.
Ruth Ann, it seems we're having more of a conversation now about lead poisoning than we maybe ever have. A lot of your work is in lead poisoning and lead mitigation. How do you use that energy in mobilizing different partners, different pieces of the community, and how has the conversation about lead mitigation changed?
Well, I think back to, we talked about this when you were in Baltimore. You know, we were begun by 9 parents whose children were poisoned by lead so badly that they were in the intensive care unit at Johns Hopkins Hospital in 1986. And yet they lived across the street from what was and is one of the greatest health institutions in the country. They set out a vision that said we have to look at these twin tragedies that we're looking at today of deteriorated housing stock and ill health, and that we needed to find a way to break that. And I do think there continues to be this surprise over the course of history of what we've known about lead. Every time there's a new story, it's like, oh my God. And we've been dealing with this for 100 years. But what we have found is lead is a symptom of poor housing condition. It's a symptom of the decisions that we've made about how we will treat dollars. And it really does go back to the common sense that we're talking about here today. When we talk about going upstream, we're really talking about going into people's homes and into their communities. And so we've been able to show a 99% reduction in lead poisoning in Baltimore and have built a body of national work around healthy, safe, and energy-efficient housing. But that 99% reduction in lead poisoning in Baltimore has yielded a $44.5 billion economic return to the state of Maryland. And I think the connection now is, how are we doing that reinvestment that actually goes to the benefit of generations who've lived with the toxic legacy? And we've taken the data and what we've learned to now make the case to Medicaid managed care, to our partners at United and Amerigroup, to say we can address asthma reduction, lead poisoning, those things that get kids healthy and ready to learn in the classroom, as cost savings, do the right thing, stabilize neighborhoods, give a better trajectory to children, and do the same thing for our seniors and care for housing as an integral part of healthcare. And that's what we're trying to do.
So you talked about these folks who are suffering from an imminently preventable condition across the street from a world-class healthcare center.
Yeah.
We are talking about communities, and it seems to me a lot of that conversation is, yes, it's about getting the policymakers involved, but it's also about getting these institutions that are geographically part of the community, that are economically part of the community, but don't necessarily see themselves as responsible for or engaged necessarily in the health of that community.
I mean,
right?
and anchor institutions go outside of healthcare, right? We are battling to get Hopkins to put community benefit dollars into the city. They're doing very good things. We have a project that we're going to take every child who's missing school for asthma in East Baltimore, go and assess their home and fix it because we know the healthcare return. But anchor institutions also go outside of that. It's the employers. So you're talking about Baltimore, it's Under Armour, it's the University of Maryland, it's Towson, it's Coppin, it's Morgan State. All of these anchor institutions have to be deeply engaged, not just studying what we talk about, but engaging and listening. Every single policy that we've ever made has come from a parent or a homeowner or a worker in the field saying, hey, you got to look bigger than lead. You got to know that people are sick, and you've got to look more holistically. If you follow those threads, we have every kind of community investment we make is a part of building equity in health.
Chris, with the Farm Bill coming, with all these different advocacy groups talking about SNAP, it does seem, in addition to the awareness about lead poisoning, we're also having a moment of talking about food justice. Can you explain to the room what your work is with food sovereignty, food justice, and how that relates back into this idea of community engagement?
Yeah, so our work is grounded in food. We have a 2-acre farm and food hub in Ward 7 here in the district. And for those who don't know, Ward 7 and Ward 8, I think we may have had some mention prior to, 95% African American, only 3 grocery stores for more than 160,000 people. Our work is really rooted on the ground, in the soil. So when we're talking about community-based solutions, we want to really get to that grassroots level, and we want to bring policymakers to that grassroots level down into the dirt, literally. So we don't want to go have conversations in the Wilson building. We want to bring people to the community. We're situated behind Kelly Miller Middle School, which has more than 400 students who predominantly receive free and reduced lunch, and Lincoln Heights, which is one of the largest public housing communities in the city. So we don't want you to be afraid to come and see where the rubber hits the road. We want to bring you into that space. And we're very fortunate on 2 levels in relation to policy. First, I have the privilege of serving on the DC Food Policy Council. So you will see Food Policy Council members engaged on the ground in the spaces that we occupy. But we're also fortunate to be very near to Congress, so that we can have another level and layer of impact by just heading down the street and again saying, you know, come on out of that marble statue, those marble structures, and come on down to where we are. Community-based solutions are about bringing more voices to the table. Some of our partners have experienced the circumstances and situations that we're talking about in a more proximity than I have myself. In doing this work, I have to recognize the privilege that I hold and work to break down those barriers so more folks can be at the table.
Do you find that all these people in these marble buildings now, are they thinking differently about the issue of food? It seems at least the lobbying has changed. There are more nuanced conversations about that.
Yeah, I think people are thinking more about food, but it's up to us to change the narrative of what the story is. We want to use food as a community economic development driver. There's a lot of opportunity for folks to be getting their own food businesses, to be able to be trained for opportunity in a new food system. But that new food system has to take on a different vision, more community ownership. So that means that more folks are owning their own businesses, more support for cooperatives and other structures and systems that allow for people to democratically access capital and be able to generate a living for themselves and their families.
You know, there's something to be said for reaching across systems. So with our agency, which we're Collective Impact, we purposely go out and reach out to folks across other systems. We use community-based agencies also to help drive the conversation. When you have communities that are speaking up in different places, going to their legislators and lawmakers, it's like the chorus rising up and saying, you have to address, for example, the high number of infant deaths coming from one particular zip code. 4 times as high as it is in the nation. You have to address unstable housing and food insecurity. And so we feel we've used the technique where it's strength in numbers, but we're creating a very diverse coalition.
Ruth Ann, so much of this relies on community health workers, on people who have actual connections to the community, also being involved and sort of leading from within, right? How does that factor in? I know we talked about this before in Baltimore. How does it factor into your work, getting people to have that stake and to be helping other folks have that stake?
Well, I think it's critically important that the best results grow from the most local places. And I'm thinking that, I was listening to Steve Nelson earlier, and he remarked that we spend 20% of our healthcare dollars on social determinants and 80% on post facto kind of healthcare. We have an opportunity in community with so many leaders who actually know the common sense solutions that exist right in front of their own community to have a true economic development engine. If we reverse that ratio of investment, I think about environmental health inspectors can make $65,000 to $85,000 a year to look at housing, and these are permanent jobs with health care benefits that people who are in communities who are underemployed and unemployed can have that pathway and career so easily in contracting work, in the work you're doing around health, around food. I think there's leadership that has to come because people know their surroundings, they know what's impacting them, they know what the risks are in their communities. But there's also so much benefit and so much savings that we will get if we flip that investment. And for us, we're trying to solve for $150 billion of avoidable cost, $50 billion on asthma, $50 billion on lead, $50 billion on preventable injuries alone, not to get to the impact, not even to touch the impact of energy efficiency on health. Those are jobs, those are local jobs that can grow into companies that are owned by communities. And what we get from that is billions of dollars of taxpayer savings, more stable communities, and kids who get to the classroom, who are going to graduate, who are going to compete, who at third grade level reading will have the 30 million word vocabulary versus the 3 million word vocabulary.
Chris, I've lived in DC for some time now, and it seems the challenge with a lot of programs in the city is the fact that so many people who live here today in Ward 7 will not live there in 2 or 3 years. And food justice is an issue tied up in that, also healthcare services, also housing. All these things are they're both factors in predicting displacement and also are negatively affected by it. How do you deal with the fact that you are your work is treating an ill that is going to also negatively affect your work? How do you deal with that?
Yes, difficult to reconcile sometimes, but we have to be unafraid to speak truth to power and talk about the intentional construction that has built the systems that keep our communities under the boot, so to speak. Displacement is happening at a pace where I don't know what to do on any given day to stop it or to slow it. But we have to be real about why those policies and those decisions that are made continue to be made. We're heading into election season, and here in the district, you'll see all these LLCs pop up. ABC 123 LLC, 123 ABC LLC, $1,000 here, $1,000 there, $1,000 here, $1,000 there. Those are the systems why we need campaign finance reform. We need to have those conversations building power on the ground that can turn over those ANCs and those council members who are afraid to say no to those numerous LLCs. Those are the influencing factors that keep the engine going. For our nonprofit partners, we're exist in a space where we have to balance those things, but we have to, at the end of the day, put community first and not our pocketbooks. It's a challenge, but it's something that has to happen.
If I can get in on that, it's very interesting. With our health workers, we build an infrastructure, essentially a pipeline to give communities a voice. And we have a particular community where residents are challenged by transportation, challenged by food access, medical care, and so forth, and easy access to employment. So we're building on the outskirts of our county, and there were lots of conversations about if we develop in a certain part of the area, will folks start moving out? Gentrification happen, folks moving in. Well, there was significant community dialogue. We had the right leaders at the table, and that includes our mayors and Department of Development and other key stakeholders. Hospitals were also in this space. And the community residents said, you're always giving tax incentives to bring new residents in. Give us a tax incentive to stay. How about that? And so just in the last 6 months, through the Rose Fellowship, Columbus did an inclusionary zoning new policy where they are now incentivizing folks who have lived there over 30 years to stay. How do we direct home repair and other things that would keep them in their house, give them a tax abatement as the property values rise so that they can remain in their homes? That stabilizes neighborhoods, right? A lot of these folks are connected to that ground, and we're building that infrastructure where they at least feel they have some level of empowerment, they have a voice, and they can stay right in their community. And we support that wholeheartedly.
I have a follow-up for you, but I do want to make sure everybody's thinking about their questions. I'll come back to you all in just a minute. Erika, bringing in a piece from the last panel I did, where we talked about the role of community leaders who are already plugged in, who are already fluent, especially in Black communities, lots of Black women who have the healthcare information of generations sort of downloaded already. How do we tap into those resources, and how do you build, you talked about building a pipeline, how do you make the formal structures work to accommodate and foster that?
So we leverage our position, frankly. Because we are in the mayor's office, we are a backbone agency, we know our role. We stay in our lane. Essentially, I just create pipelines for community leaders to come through and have a seat at the table with influencers that can change policy. And that has always been our mission. We do it for residents, we do it for hospital executives, we do it for community leaders, faith leaders, and quite frankly, Columbus has embraced this way of doing business. And that's the coalition that I speak of. It's a very powerful tool to be able to have folks stand shoulder to shoulder and say, this is why we should do this as a community. And quite frankly, we've made significant allies with those community mothers and fathers and grandmothers that don't feel like we're in competition. We're just trying to ease the path, quite frankly.
Can I jump a little bit on that? Because the community health needs assessment that nonprofit hospitals go through every 3 years, they ask people like us to be at that table. Yeah. And what really has to change here is to ask those grandmothers, ask the young people who are coming up, who are engaged, and really have a better dialogue of what is happening. But the idea of solutions that work over time, I've been doing it for 25 years, and it's still those solutions that you hear. That's the cross-sector partnership that actually bears real fruit, that we all want to draw from, but it has to be done in a way that is engaged. So I'm so excited about this incentive program we have in Columbus about getting people and turning the dollars to the people who are living this and helping to solve for the problems. But that's part of what I think has to happen.
Just as a last statement on that, if the community doesn't embrace it, it's not sustainable. And so we really see engaging members of the community to co-design solutions is the sustainability model. Because if they don't embrace it, we're just there temporarily.
All right, and with that, we'll have questions. One right here.
Thanks. Ryan Moser at Corporation for Supportive Housing. So first off, this may be my favorite discussion of the day. Really fascinating. Second, as a question, so you talked a little bit about about food infrastructure, about housing maintenance infrastructure. Can you put your brains towards what does that community health center growth lead to as far as a health delivery infrastructure in thinking about that 20%, and how should communities be included in thinking through the design of what that looks like and how to deliver it?
You want to jump in on food first?
Yeah, so I mean, from the food perspective, if you're building out a hospital, that hospital is going to have institutional purchasing, right? So what does it look like to have community members have more ownership over the infrastructure, the physical infrastructure, say cold storage, refrigerated trucking, a farm that could actually produce or aggregate and supply that hospital with its food needs in a way that then creates jobs for folks that may have barriers to employment. So if you're building out these institutions in the community, how do you upskill the folks that are in that neighborhood to be able to access what employment may come or what entrepreneurial opportunities may come? So I think, community health benefit dollars have a role to play, foundations, and there's a role for government to play. We have to, again, acknowledge that government has played a role in developing and influencing the circumstances that keep people oppressed, and that has to have a role in uplifting people as well.
I think on the housing maintenance, I know you're behind the thing, I can't see you, but Brian. But I think if we've taken an approach of aligning the resources that exist for housing and trying to maximize that delivery to lower the impact on how families experience getting their houses fixed. Right? We looked at our system and said for a family to go after the 5 or 6 grants that they need to get their houses fixed, which will improve their health, they would miss 23 days of work. And if they don't do that, they will have their kid in the hospital for 3 and 4 weeks a year for asthma. And so we had to kind of solve for that and streamline that and then say to Medicaid managed care especially. So if you know that what we're going to do is do work that will improve the rates of asthma or lower the rates of asthma, reduce emergency visits and hospitalizations, and have big economic outcomes, managed care has to be a part of that alignment. And I think following that outcomes-based alignment has been critical.
Erika, wanted to give you the
only
closing
thing
word.
I jump in on is around community health workers, and I think I've heard this talked about in a couple of earlier sessions. Integrating that health worker into a care model with hospitals and clinics is real. That we have a real opportunity there. If we're hiring health workers from neighborhoods where they have the relationships, they understand what's happening on the ground, being able to incorporate their voice and them as a part of the care team, the integrated care team, seems like a solid pathway going forward.
Well, Baltimore, D.C., Columbus, looks like we got some good folks working there.
Thank you.
Well, thank you all for coming, and thank you all for being here.
Thank you.